let's talk about tuberculosis affecting the musculoskeletal system, the classical Koch's weak bacillus, this paucibacillary organism infecting the bone. The first thing that you need to understand is a general point that I wanted to mention that I already did in the beginning, but again I'm repeating, that the infection by the tuberculosis has usually less severe local manifestations compared to pyogenic organisms. Nevertheless, everything again is written in the slides. I want you to understand the story, understand the concept, and then you can write your notes. The organism causing tuberculosis is obviously Mycobacterium tuberculosis. Now, what is the most common site of TB in the body? You would say spine. No, don't say that, because I'm orthopedic surgeon, you're answering bone. I said in the body. In the body, it is lungs. Okay, it is lungs. But in the musculoskeletal system, yes, it is the spine, followed by hip, followed by knee, right? So it is the spine, followed by hip, followed by knee. You see, TB in the spine, we call it TB spondylitis. And TB in the joints, we call TB arthritis. So TB hip is hip arthritis. A TB knee is knee arthritis. TB spine is TB spondylitis. Simple. Now, what is the most common part of the spine, or which spine is most commonly affected? The best answer is dorsolumbar, that is thoracolumbar. If that is not given in the options, then you can mark dorsal, that is thoracic, followed by lumbar. So in overall, spine, dorsolumbar is most commonly affected. If dorsolumbar is not given, you can say dorsal, followed by lumbar. In children, it is the cervical spine that is most commonly affected. And just like any infection in the body that comes to the bone, it is usually hematogenous. Okay? That you know. Right. So there are three types of tuberculosis that we are going to read. That is the TB of the spine, TB of the hip, and TB of the knee. There are other variants also. There are rare variants also. You just need to know a few points about them. I'll just mention it here and then we'll forget about it. Caries-Sicca is basically tuberculosis of the shoulder. Caries-Sicca. Sicca means dry. It is a dry TB. Means there is low exudation. There is low or no exudation. The granulation tissue and are such less. So this is known as Caries-Sicca. It's a dry tuberculosis affecting the shoulder. Another one is tuberculosis of the short bones of the hand and feet, known as spina ventosa. Tuberculosis of the fingers. This is known as spina ventosa. Ventosa means filling something with air. It's like this phalanges swell up like swelling of a balloon or swelling of a ball. That's known as spina ventosa or TB dactylitis. This is TB dactylitis or spina ventosa. You need to remember this. So TB of the phalanges or the finger, spina ventosa, TB dactylitis. Caries-Sicca is TB of the shoulder, which is dry. Okay, with that, let's move on to the spine, hip, and knee. In the spine, tuberculosis most commonly affects the dorsolumbar. Right. Now, there are variations of tuberculosis that affect the spine depending on where they affect the spine. What are the types? Paradiscal, central, anterior, and posterior. This is your vertebral body. This is another vertebral body. And this is the intervening intervertebral disc. And these are the posterior elements. The most common variety of tuberculosis that affects the spine is paradiscal. Means it involves the disc and the lower half of the upper vertebrae and the upper half of the lower vertebrae. Very, very important. Paradiscal. It's a disc and bone disease. This is the most common type of tuberculosis of the spine, paradiscal. Other types are central. Then you have anterior, that usually occurs in children, and rarest of all is posterior. Posterior elements are rarely involved. Now please remember that tuberculosis of the spine is usually a two vertebrae disease. It's usually a two vertebrae disease affecting the upper and lower vertebra and usually involves the disc, because the most common type of TB spine is paradiscal. And the reason, there is a reason behind this. It's a scientific reason. What is the reason? It's the blood supply. You see, the disc and the lower half of the upper vertebrae and the upper half of the lower vertebrae take blood supply from a common source embryologically. Embryologically, they are considered as a sclerotome or a somite. They have a common blood supply. I'm showing you the blood supply here. This blood supply supplies the lower half of the upper vertebrae and the upper half of lower vertebrae. And this is the reason tuberculosis most commonly involves the paradiscal region. Very simple. It's embryologic. Okay. So it involves the bone and the disc. Okay. And the organism thrives here, grows here, causes destruction here. All of it in front of the spinal cord, anterior to the neural elements. So here is where the organism will start to grow, behind which is your spinal cord. The problem is, if there is TB limited to the bone, you call it tuberculosis of the spine, and that is the TB infecting the bone, TB spondylitis. But if this infection or the granulation of this infection goes and starts compressing the spinal cord behind, then there is neurological manifestation of tuberculosis of the spine. Then we call it POTS paraplegia. Okay? TB spine or POTS spine is the infection of the bone. POTS paraplegia is when this infection of the bone starts to compress the neural elements, that is the spinal cord which is behind it, and then presents to you with paraplegia. Right? Are you understanding? There are two differences here. So TB spine is tuberculosis of the bone. POTS paraplegia is basically this tuberculosis compressing the neural elements and manifesting as paraplegia. And obviously, this is the spectrum of the disease. If you do not treat POTS spine, it will eventually go into POTS paraplegia. Okay. Now, what will be the clinical features of a patient with tuberculosis of the spine? Please remember, tuberculosis presenting anywhere in the body will have constitutional symptoms that are same everywhere. So, what are the constitutional symptoms? Patient will have low-grade fever, malaise, evening rise of temperature, night pains. All of these things will be there. So, this is common. This is non-specific. What are the local findings that are specific for TB spine? So the local findings are interesting here. The local finding, earliest finding or the earliest symptom would be pain. The patient will complain of pain in the spine or pain in the back. Which is the earliest symptom, pain in the back. Sometimes they ask you what is the earliest sign. Now listen to me. Because of this pain in the back, the patient will refuse to move the back. So if he wants to keep his back stiff and straight, what will he do? He will use the muscles around the spine to keep it in straight position. For that, the muscles have to be in spasm. The muscles have to be contracted. And over time, these muscles that are contracted will go into spasm. And so they will be tense and swollen. So if you take your hand and rub it on the back, you will notice that there is paraspinal muscle spasm. So earliest symptom is pain, earliest sign is paraspinal muscle spasm. This is how they frame MCQs. And why is the patient in paraspinal muscle spasm? Because he doesn't want the spine to move. And why doesn't he want to move? Because if he moves, there will be pain. Because there is destruction of the vertebra because of tuberculosis. Right? Because of tuberculosis. So patient will have a very cautious gait. He will have a military attitude. What is military attitude? He'll be sitting erect and straight without moving, and he will turn around very slowly and carefully, and he will have a cautious gait. Cold abscess, yes, it's an abscess that will be seen in tuberculosis. What else? What else? There will be destruction of this vertebrae, right? And because of this destruction of the vertebrae by tuberculosis, there will be vertebral collapse. And when there will be vertebral collapse, there will be a deformity. What are these deformities? Vertebral destruction leads to collapse of the vertebrae, which causes deformity. And when this deformity happens, the post elements clinically become more palpable or prominent. So if you take your finger and rub it on the spinous process from top to bottom, what will you notice? You will notice an abnormal peculiar bulges happening around the site of infection. So if these bulges are palpable, you have different names for these bulges. You call it a knuckle if the prominence is of one spinous process. You call it a gibbous if the prominence is of 2 or 3 spinous process, or you call it angular kyphosis if the prominence is more than 3 spinous process. So you see, because of the collapse, because of the vertebral collapse, the spinous process becomes prominent. Okay, you can see angular kyphosis, you can see gibbous here. So knuckle, gibbous and kyphosis. Let me show you a real case of gibbous here. You see this on the lateral x-rays, and clinically there is a gibbous here. That's all you need to know. You need to know knuckle, gibbous and kyphosis. X-ray findings. What are the X-ray findings you will notice in tuberculosis of the spine? The earliest X-ray finding is narrowing of disc space. So you see this is vertebra, disc, vertebra. The disease process has started here. So what will happen? There will be disease growing in the lower half of the upper vertebra, upper half of the lower vertebra. The disc will not get the nutrition it is supposed to get because it usually gets its nutrition from the end plates. So what will happen? The disc will start to desiccate, and so the space on X-ray will be reduced. So disc space narrowing. What else will you notice on X-ray? There will be paravertebral abscess. Because of the destruction around the vertebra, there will be abscess, paravertebral abscess, and obviously vertebral destruction or vertebral lysis. So narrowing of disc space, paravertebral abscess and vertebral destruction or lysis. These are the X-ray findings. Investigation of choice is obviously MRI. And what will you notice? The disc is involved and there is a paradiscal disease, meaning disc involvement, and lower half of the upper vertebrae and upper half of lower vertebrae will be involved. If they ask you what is the gold standard investigation of infection, then you will say CT guided biopsy, because I've been telling you biopsy, biopsy and biopsy. Go and identify the bug in the tissue itself. To make the diagnosis here, you take the help of CT to guide your biopsy to make the perfect diagnosis. Now, what is the end sequelae of tuberculosis of the spine? If you recall from ankylosis, I told you TB everywhere undergoes fibrous ankylosis, but in the spine, it undergoes bony ankylosis. So the end result of a neglected Pott's spine would be bony ankylosis or fusion of the spine. Now, this is your Pott's spine. Now, over time, this Pott's spine will manifest as Pott's paraplegia, because the granulation tissue will start to compress the spinal cord, and that is when you will have your neurological symptoms. So what is Pott's paraplegia? It's due to the compression of the spinal cord by TB spine disease process. Patient will have neurological symptoms. Now they will ask you, why? Why will the spinal cord compression happen? So what are the causes of cord compression? There are three important causes. First, obviously, is the mechanical cause, because of the granulation tissue which will compress the spinal cord. Look at this. This is an MRI showing you paradiscal involvement with the granulation tissue impinging or compressing the spinal cord, mechanical cause. Second, cord edema. Because of this local inflammation that is happening, the spinal cord will go into edema, and this edema will cause compression. Third is, because of the granulation tissue and infection, the vessels, the spinal arteries, they undergoes thrombosis. And because of thrombosis of the spinal arteries, the spinal cord will not get the blood supply and go into ischemia. This is very dangerous. This is very dangerous. This is a rapid onset paraplegia in a patient of tuberculosis of the spine. Poor prognosis. Vessels have gone into thrombosis, spinal cord will go into ischemia. So remember this, keep this in mind. Spinal artery thrombosis will give you rapid onset paraplegia in a patient with tuberculosis of the spine. Okay. Now they will ask you the neurological symptoms. What is the earliest neurological symptom? What is the latest neurological symptom in a patient with tuberculosis of the spine? The earliest neurological sign is upper motor neuron lesion or lower motor neuron lesion? Upper motor neuron lesion, because it's dorsal-lumbar. Dorsal-lumbar lesions will compress the spinal cord. So earliest upper motor neuron lesion will be ankle clonus or exaggeration of the deep tendon reflexes, followed by extensor plantars. So remember, earliest neurological manifestations are upper motor neuron lesion like manifestations in terms of ankle clonus or exaggerated deep tendon reflexes or extensor plantars. Very late in the disease process, bowel and bladder involvement will be seen. Very late in the disease process, bowel bladder involvement will be seen, and usually when the patient has bowel bladder involvement because of tuberculosis of the spine manifesting as Pott's paraplegia, the prognosis has become poor because it's already too late in the disease process. We have certain prognostic factors telling us which type of Pott's spine have better outcomes compared to other. The list is there, you can read it yourself, but I'll try to simplify it for you. What you need to remember is age. Younger people have better prognosis compared to older people, and the type of the disease. Early onset of the disease usually have better prognosis compared to late onset of the disease. What do you mean early onset, late onset? Early onset of the disease means early onset compression of the spinal cord usually happens because of granulation tissue of the TB. Late onset disease is usually because of the bony deformity that happens. So granulation tissue ke wajah se, if there is a deformity, if there is a compression of the spinal cord because of this granulation tissue, on treatment of tuberculosis, this granulation tissue will go away. So this compression will go away. So that's why it has better prognosis compared to the bony compression that occurs later on in the disease. Right? So early onset has better prognosis compared to late onset. Early onset has better prognosis compared to late onset. Similarly, slow onset of paraplegia has better prognosis compared to rapid onset, because I told you rapid onset paraplegia is because of spinal artery thrombosis. I told you that. Rapid onset has poorer prognosis. Finally, short history has better prognosis compared to long history, which again means short history means there is granulation that is causing the compression of the spinal cord. That's why it has better prognosis. Long history, it means that the disease process is so long that the compression now is because of the bony deformity rather than the granulation tissue. Everything else is simple and self-explanatory. I thought these three you need to be explained. Now, how do you treat this Pott's paraplegia or Pott's spine? See, we follow something known as a middle path regime. And why did it come into existence? What is this middle path regime? Simple. You see, India, being a developing country, did not have a lot of resources when we started the treatment of tuberculosis of the spine. So we usually treated them with conservative management, anti-tubercular therapy. Whereas the Western countries, they were financially, well off, they would aggressively treat tuberculosis of the spine surgically because they didn't want that granulation tissue compressing the spinal cord. So there were these two thoughts, conservative and surgical. In 1970s, Dr. S.M. Tully, a very popular orthopedic surgeon, still alive, he came up with something beautiful. He said something known as a middle path regime, where he said that we neither have to be very conservative nor very aggressive in the management of tuberculosis of the spine. We have to follow the middle path regime. So what is this middle path regime? He said, start the patient on anti-tubercular treatment for 18 to 24 months. Again, the duration is more because you want the antibiotics to penetrate the bone, which have less penetration by the antibiotics. So duration is high. Compared to any other tuberculosis of the body, a bone penetration is a little low by the drug, so you need to give it for a longer duration. Start the patient on anti-tubercular therapy, give him rest, apply a brace, MCQ is there, it's called a Taylor's brace that supports the dorsal lumbar spine. You start him on that and then you observe. If the patient is improving, then there is nothing that you need to do. Continue the ATT, the patient will improve. But if the patient is not improving over a course of few weeks, or is worsening, or if there is a bowel bladder involvement, or if there is a neurological manifestation already, in that case, conservative management goes out of the window and you have to go for surgical decompression. Okay, then you have to go for surgical decompression. Go in surgically, remove the granulation tissue, decompress the compression that is occurring on the spinal cord to relieve the neurological symptoms. That is the beautiful middle path regime. So let's see the surgical decompression. What is the approach that you will use? You will use the left anterolateral decompression. You see, whenever you're operating on the spine, you operate it from behind, posteriorly, right? We've talked about this in spine. We've talked about it in scoliosis. You approach it from behind and you put those screws through the pedicle, right, to stabilize the spine. Now in TB, I told you the disease process already involves the anterior part of the spine. Now if you go from posterior, what will happen? Anterior is destroyed by the disease process and now you're approaching it posteriorly, destroying it from the posterior side as well. So the spine will become very unstable. So it was believed that it is best not to touch the spine of TB from behind. But nowadays, we are going from posterior as well. But you need to know this for your exam. So instead of going posteriorly, you are supposed to go anteriorly. Now, what are the options of reaching the spine anteriorly to operate and decompress? You cannot go anteriorly directly like this, right? It's a very difficult approach because a lot of important structures will come on the way. So you have to approach laterally, anterolaterally. Now, there are two ways of approaching anterolaterally for decompression. Right anterolateral, left anterolateral. If you go from the right anterolateral, you will encounter inferior vena cava. And if you go from the left anterolateral, you will encounter the aorta. Which side will you prefer for decompression? Or rather, which structure would you rather encounter while you are operating? Don't say inferior vena cava. Don't say inferior vena cava. Because inferior vena cava, although it carries deoxygenated blood, is an important structure nevertheless. You see, if you go from the right anterolateral side and you injure the vena cava, it will be impossible to repair it because veins are flimsy. Whereas if you go from the left anterolateral side, even if you injure the aorta, you can still take bites and suture it and repair it because aorta is a very muscular structure. So you prefer the left anterolateral approach. You dissect the anatomy, move the aorta away, and then do the decompression. And while you're doing the decompression, there are certain structures you remove from the spine so that all the contents are removed. So what are those structures that you remove? Obviously the rib, the transverse process, the pedicle, these are the structures you remove, and the infected vertebral body and the disc. All of these structures you remove without disturbing the posterior elements. That is known as your anterolateral decompression, which we prefer from the left side. Okay? That is the surgical treatment of tuberculosis of the spine. Now, whenever we talk about TB of the spine, we also have to talk about another thing that most commonly affects the spine. That is your metastasis. And the reason for this is your diagnosis depends on this on your exam. There will be an X-ray or an MRI or a CT that will be given to you, and there will be a lesion in the spine. And if you're not careful, you might misdiagnose it as either TB or metastasis because both of them occur in the spine. So how do you differentiate? Remember, TB involves the disc because it's paradiscal. And metastasis never involve the disc. So keep this in your mind. If there is a disc that is involved, then it is usually TB. And if the disc is spared and there is a lesion in the spine, it is usually metastasis. A very popular phrase in orthopedics where they say, good disc is bad news and bad disc is good news. What does it mean? Good disc is bad news means if the disc is good and it's not involved, it is bad news for the patient because the patient has metastasis. And bad disc is good news because if the disc is involved, it means the patient has tuberculosis, which is treatable. We can treat tuberculosis. We cannot treat metastasis. Are you following? So good disc is bad news. Bad disc is good news. That is what you need to remember. Okay. So here again, the disease is paradiscal. It involves the disc and lower half of the upper vertebrae and upper half of lower vertebrae. Here the disease process only involves the spine and not the disc. Remember in metastasis, we read there is one more finding that is seen on X-ray. Right. The winking oval sign where there is destruction of the pedicle. Right. Destruction of the pedicle, the winking oval sign. The winking oval sign. So these are the findings that you will see in TB of the spine, and this is how you differentiate TB spine from metastasis of the spine. Now let's talk about tuberculosis arthritis, that is TB arthritis. So let's talk about the TB that affects the hip and the knee. TB arthritis, same thing as the TB spondylitis. The source of infection is hematogenous. The organism reaches the hip joint from the blood, from some primary source anywhere in the body. And in the hip, where does it most commonly occur? It most commonly starts at the acetabulum. Please remember that. Okay. So this is your hip joint. It most commonly starts at the hip joint. The other common location is this triangle in the neck of the femur known as Babcock's triangle, and the usual reason here is that because it has less defense cells or your monocytes and macrophages, so organism thrives there. But usually it starts in the acetabulum followed by Babcock's triangle. Again, tuberculosis anywhere in the body will give you constitutional symptoms and local symptoms. Local symptoms will be pain at the hip. So because of this pain at the hip, the patient will have difficulty walking or painful limb known as antalgic limb or antalgic gait. There will be destruction of the hip, which will lead to limb shortening and deformities. So all of these clinical features can be presented to you in a form of a stage of the disease. We have 5 stages of the disease: synovitis, early arthritis, late arthritis, wandering acetabulum, and fibrous ankylosis. Wandering acetabulum stage is also known as advanced arthritis stage. Okay, so let me give you a few points about what these stages show you. In the stage of synovitis, the patient will have inflammation of the synovium, and because of this there will be effusion, and because of this there will be stretch of the capsule, and because of this there will be pain. So patient will keep the hip in a position of ease, which is flexion, abduction, external rotation. Right? What is the position? Flexion, abduction, external rotation. And in this position, the limb will appear to be lengthened than it actually is. It will only appear, that's why it's called apparent lengthening, the stage of apparent lengthening. So patient will have stage of synovitis, the limb will be apparently lengthened and in abduction and external rotation. Now after this stage, what happens? The articular cartilage starts to destroy. So this is known as the stage of early arthritis. So there will be apparent shortening of less than 1 centimeter, but the attitude of the limb will change. Here the limb will be in flexion, adduction and internal rotation. Okay. Now this is early arthritis. Late arthritis is where there is significant destruction of the articular surface because of the disease process, and this will lead to more shortening, that is more than 1 centimeter, and the attitude will still remain the same of flexion, adduction, internal rotation. So patient has an attitude of flexion, adduction, internal rotation and shortening of around 2 to 3 centimeters. In tuberculosis of the hip, his stage is usually late arthritis or stage 3. In advanced arthritis, the head is almost completely destroyed and it will appear as if a large acetabulum holds a small head. This has been described as a pestle and motor deformity. So pestle and motor, if you don't know, is something like this, right? So this is your pestle and motor deformity. It looks like the acetabulum is large and the head of femur is small because the head of femur is completely destroyed. This is the stage of advanced arthritis. And finally, the last stage of tubercular arthritis is ankylosis. And can you tell me which type of ankylosis? Yes, it's fibrous ankylosis. It's fibrous ankylosis, where there is a painful, a little bit mobile, unstable hip. These are the stages of tuberculosis of the hip. Sometimes they ask you the radiological findings. What is the earliest X-ray finding of the tuberculosis of the hip? The earliest X-ray finding is juxta-articular osteopenia or osteoporosis. Because of infection, there is inflammation, and because of this inflammation, there is more or increased hyperemia of the bone. This will manifest as osteoporosis or osteopenia just under the articular surface. That is called juxta-articular osteopenia. There will be peripheral erosions, and eventually there will be a narrowing of the disc space or the joint space. In this case it's joint space, and in the case of spine it's disc space. So juxta-articular osteopenia or osteoporosis, peripheral erosions because of inflammation, and narrowing of the joint space. These are the findings that you will pick up on X-ray in terms of tuberculosis of the hip, and they have given a term for it. It's called a Five-Mesters triad in TB hip. Five-Mesters triad. What is the treatment? Just like any TB anywhere, start anti-tubercular treatment, give the patient rest, keep the limb in traction so that the head doesn't get destroyed. If the patient is recovering, great. If not, you can go for surgical decompression. So early anti-tubercular treatment, rest and tractions, they will do the job. If the patient is not recovering, then you will have to go for a decompression and remove the contents of the hip. Later, anti-tubercular treatment, curettage and correct the deformity. Now, what types of deformities will you get? We've discussed the deformities here. If it's a fibrous ankylosis, then you will want to make it a mobile hip. Then what are the options to make it a mobile hip? You have a few options in hand. Best is to go for a total hip replacement because the hip is destroyed. You replace the hip, but you only do it after 10 to 15 years post-infection, because if you do an arthroplasty fresh out of the infection, there is a very strong risk of recurrence of infection. So usually 10 to 15 years of the disease period being passed away, then you will go for total hip replacement. Any other options available? Patients who are not affordable of total hip replacement, or patients who cannot undergo total hip replacement, or who have contraindications for total hip replacement, what are the other options you have? You can go for excisional arthroplasty, where you remove whatever little fibrous ankylosed head is there. You just go ahead and remove it, and you interpose it with a muscle. So for example, if this is the acetabulum and this is the head of the femur and the neck of the femur, and there is fibrous ankylosis that has formed, what you do is surgically go inside and remove all of this. You will have acetabulum and you will have a neck of the femur, and you interpose a muscle between the head and the acetabulum, between the neck and the acetabulum, and this muscle will not allow the bone to grow into each other, and this is your Girdlestone excisional arthroplasty. Or another option is, if patient doesn't want a mobile hip, we can fuse the hip, that is known as arthrodesis. These are the options that you can offer, but the best treatment would be a total hip replacement. That is about TB of the hip. Same thing for tuberculosis of the knee, friends. The patient will have tuberculosis of the knee. There will be constitutional symptoms, painful limb, antalgic gait. There will be shortening and deformities. And what will be the attitude of the knee? Because there is synovitis initially, there will be swelling, there will be tense capsule, and there will be pain. So patient will keep the knee in slight flexion, 5 to 30 degrees. That is the position of ease of the knee. Investigation of choice is MRI. You will see synovitis, but the gold standard investigation remains in infection is biopsy. Go ahead and remove the tissue. Early stages, I've told you, there will be synovitis and position of ease. And late stages, where there is destruction of the articular cartilage of the knee joint, you will have a classical deformity. That deformity has been asked as an exam MCQ. That deformity is triple deformity. So what are the parameters of this deformity? The parameters can be remembered in the mnemonic PERF. There is posterior subluxation of the knee, there is external rotation of the tibia, and there is flexion of the knee. So this is the deformity that you will see in the knee. Again, what is the treatment? The treatment is anti-tubercular treatment and traction. And if there is destruction of the joint, then you can go for either arthrodesis, fuse it, or arthroplasty, but you will do arthroplasty only after the disease process has been quiescent for a significant period of 10 to 15 years. Right? So these are the things I want you to remember about tuberculosis of the spine, hip, and the knee. And not a lot of details, but definitely a lot of facts that you need to remember for your exam. Now let's practice a few MCQs in order to appreciate what is being tested on the exam. Now let's look at the first MCQ. Phelon is infection of the nail fold, infection of the ulnar bursa, infection of the pulp space, or infection of the TIP joint. What is the answer? Yes, it's the infection of the pulp space, because paronychia is what is the infection of the nail fold. Right? Now, next MCQ is true about chronic osteomyelitis, all except. Okay, so what is the false statement? Non-healing sinus is most frequently due to presence of sequestrum. Yes, it's true statement. It's because of the sequestrum, the organism keeps on thriving and growing, which is a dead bone. It keeps on thriving and growing. The pus keeps on accumulating and keeps on discharging through the sinus. Sequestrum is heavier than the live bone and trabeculated? No. Sequestrum is a dead bone. It's a dense bone. It's a light bone. And the Haversian system is destroyed. It's not trabeculated anymore. So this is false statement. Involucrum is the live, dense, sclerotic, periosteal bone formation around the sequestrum. Pretty much that's the definition of it, right? It's the new bone that forms around the sequestrum in order to prevent its spread. Complications include amyloidosis and sepsis. Yes, they include amyloidosis and sepsis. So the answer here is B. Next, cloaca is located in the sequestrum, involucrum, normal bone or myositis ossificans. Cloaca is the opening in the involucrum through which the pus drains out. Right. So it's in the involucrum. That's the answer. Next, Brody's abscess is a type of acute, subacute, chronic osteomyelitis or septic arthritis. So Brody's abscess is a type of subacute osteomyelitis. Gary's sclerosing osteomyelitis is a type of chronic osteomyelitis. Which of the following is not true regarding tubercular osteomyelitis? Okay, which is not true? It is secondary TB. Yes, tubercular osteomyelitis is secondary. Yes. Hematogenous, it comes from a hematogenous source from some other primary. Periosteal reaction is seen. I told you TB, local reactions are less, unless it is spina ventosa, where local reaction is very severe. So periosteal reaction is not seen. So this is a false statement. Sequestrum is uncommon. Yes, absolutely. There is no sequestrum. Inflammation is minimum. Yes, true. Inflammation is minimum. So the answer here is B. Is that clear? Right. Chondrolysis occurs commonly in which type of pathology? Chondrolysis, destruction of the cartilage. Where have we read this? TB arthritis, syphilitic arthritis, chondrosarcoma, septic arthritis of infancy, septic arthritis in adults. Chondrolysis, destruction of the head, which is made up of cartilage in children less than 1 year, affected because of septic arthritis of the hip. So answer here is D. Okay? That is chondrolysis. And what will be the manifestation of this destruction of the head? Shortening, deformity, hypermobile hip, and positive telescopy will be there. Most common joint involved in septic arthritis. Yes, you know this. Knee is the most common joint involved in septic arthritis. But in infants less than 1 year, it is the hip. That is Tom Smith's arthritis. What is the most common site of TB in the musculoskeletal system? Spine, knee, hip, shoulder. It is the spine. The correct answer is the dorsal-lumbar spine. If that is not given in the options, then you can say dorsal followed by lumbar. And in children, it is the cervical spine. We know this. All are true about spinal tuberculosis except back pain is the earliest symptom. Yes. Dorsal lumbar spine is the commonest site. Yes. Exaggerated lumbar lordosis is a prominent clinical feature. Is it exaggerated lumbar lordosis or loss of lumbar lordosis because of vertebral compression? It is loss of lumbar lordosis. So this is a false statement. It is usually secondary to pulmonary infection. Yes, this is true. So the answer here is C. Exaggerated lumbar lordosis is not a prominent clinical feature. In fact, it is a loss of lumbar lordosis. It is the loss of lumbar lordosis. I told you, it is the anterior disease. It's anterior to the neural elements and which lead to vertebral compression. And when there is vertebral compression, it will lead to kyphosis. The spine will bend forward. That's why you get the knuckle, the gibbous, the angular kyphosis. Tuberculosis of the spine least likely involves which part of the vertebrae? Body, lamina, spinous process, pedicle. I've told you as you go posteriorly, it becomes more rare. So body is common, lamina is okay, spinous process is very, very rare. So the answer here is spinous process. Right? But the most common type of tuberculosis of the spine is paradiscal type. It's paradiscal. Now all are true about spinal TB and paraplegia except paraplegia is commonest in the TB of the upper thoracic region. Yes, that is true. And the reason is that the spinal cord is thicker in the upper thoracic region and the organism and its granulation tissue can compress this thickened spinal cord early and cause manifestation. Paraplegia is caused by spinal cord edema. Yes, it is because of inflammation. There can be a cord edema. Most common sequelae is bony ankylosis. In terms of spine, yes. TB of the spine will end up in bony ankylosis. TB anywhere else will end up in fibrous ankylosis. Most common sequelae is fibrous ankylosis. No. In spine, not fibrous ankylosis. It's only in TB arthritis, that is the TB of the knee and hip, you get fibrous ankylosis. Okay? In TB thoracic spine, the earliest sign of cord compression is. What is the earliest sign of cord compression? They are basically asking you the neurological symptoms. Bladder dysfunctions, pretty late in the disease. Motor weakness, yeah, can happen. Extensor plantar, yes, UMN lesion is an extensor plantar. Sensory loss also a little late. So the correct answer is C, extensor plantar. Remember, in tuberculosis of the spine, when the spinal cord is getting involved, it will usually show a UMN lesion where there is exaggerated of deep tendon reflexes or ankle clonus and extensor plantar. Poor prognostic indicators of POTS paraplegia is early onset disease, active disease, heel disease, or wet lesion. In which of this disease process, if you get paraplegia, is considered as poor? The correct answer is heel disease, because now you know the reason for paraplegia is the bony deformity, that is the kyphosis, that is the problem. So the treatment would be a little difficult. So heel disease usually has poor prognostic factors. This is the table that I want you to go through again. And the better prognosis and the poor prognosis, it's the heel disease that has poorer prognosis. And also remember, rapid onset of the disease is usually because of a spinal artery thrombosis that will lead to ischemia of the spinal cord. The first radiological sign of TB spine is, what is the first or the earliest radiological sign of the TB spine? Narrowing of the intervertebral disc space, yes. Rarefaction of vertebral bodies, not much. Destruction of lamina, no. Fusion of the spine has processed very, very late. So the correct answer here is narrowing of the intervertebral disc space. Now, a 50-year-old known alcoholic presented with pain in the dorsal spine. On examination, there is tenderness in the dorsolumbar junction. Radiograph shows destruction of the 12th dorsal vertebrae with loss of the disc space between D12 and L1 vertebrae. With a hazy paravertebral shadow, the most probable diagnosis is, it's clear, right? So the disc is involved. There is a paravertebral shadow. What is it? It is tuberculosis. It's a metastatic spine disease? No, why not? Because the disc is involved. How are you saying the disc is involved? There is loss of disc space between D12 and L1. Is it POTS spine? Very likely. Missed trauma? No, because there is no talk about a fracture here. Multiple myeloma? No. So the correct answer here is POTS spine. Are you following how we approached this question step by step? Look at the disc. Good disc, bad news. Bad disc, good news. Now for a patient with D7 and D8 Cox spine with paraplegia, what is the treatment of choice? Just AKT or ATT, or anterolateral decompression and ATT, laminectomy or posterior decompression and ATT. The patient has Cox spine with paraplegia. He already has a neurological deficit. Would you want to wait it out? No, you don't want to wait it out. You have to go in for a decompression. Which type of decompression will you prefer? You will prefer anterolateral decompression going from the left side. Which term best describes tuberculosis of the hand and feet? Please tell me. Yes, it is spina ventosa. It is spina ventosa. And Kari sicca is dry TB affecting the shoulder, non-exudative. Very good. Tuberculous arthritis in advanced cases lead to, what is the end outcome or end product of advanced tubercular arthritis? Fibrous ankylosis, bony ankylosis, loose joints, or Charcot's joint. The correct answer here is fibrous ankylosis. Only in the spine tuberculosis will end up with bony ankylosis. Otherwise, everywhere else it will end up with fibrous ankylosis. Please remember that. Loose joints, I don't know what he's talking about. Charcot joint, yes, Charcot joint is neuropathic joint seen in your syphilis. And apart from syphilis, there are many other conditions like diabetes and syringomyelia, which will also give you your Charcot joint. Now, apparent lengthening is seen in which stage of TB hip? So you need to know the stages of TB hip. There is a stage of synovitis, early arthritis, late arthritis, advanced arthritis, and fibrous ankylosis. So which stage will give you lengthening? First stage, that is the stage of synovitis, where the patient will have flexion, abduction, external rotation with apparent lengthening. So the correct answer is stage 1. So please go through all of these stages that are important. Just know where you will get lengthening, where you will get shortening, where you will get less than 1 centimeter or apparent shortening, where will you get more than 1 centimeter and true shortening, and what is wandering acetabulum, where you will get positive telescopy test. With that, we have completed tuberculosis of the spine. I'm sure there are a lot of things that you have to remember. I've told you in the beginning itself, infections is a topic where there is a lot of memorization rather than understanding. But if you still stick to the fundamentals and basics that I've talked about, you will not be lost. and come back to this and review again and again, because a lot of MCQs come from infection, particularly your osteomyelitis and septic arthritis.